There is no one single event that you can point to explain why a cell dies.
At Harvard, Joanne Ingwall studies the biochemical mechanisms of myocardial injury.
One of the ones we know is important is the loss of the ability of the cell to recover normal ATP levels and normal function.
In one of their models of ischemia and reperfusion, her group monitors high-energy phosphate concentrations in Langendorf perfused rat hearts with a nuclear magnetic resonance spectrometer. Ingwall is particularly interested to see if supplying inosine, a product of ATP catabolism, can prevent the catastrophic loss of purines that occurs in oxygen-deprived cells. Most of these experiments had been done under conditions of high-flow hypoxia, but on the day we filmed, the group decided to simulate true ischemia by clamping off the flow of perfusate for a period of 15 minutes.
The reason why I chose high-flow severe hypoxia as the initial model for these studies was that the high flow ensured that in the normal injury condition, loss of purines would be maximized down the concentration gradient. Just as soon as you were able to form freely diffusible nucleosides and bases, you would wash them away. And conversely, in the inosine-supplied hearts, if there would be a lot of inosine around all the time, so presumably reversing the concentration gradient so nucleoside would go in the cell instead of being maximally washed out of the cell.
The spectrometer revises its assay of phosphate concentrations every 2 minutes. During insult, the first peak, which represents low-energy inorganic phosphate, increases, while the remaining peaks, those for creatine phosphate and the 3 phosphates of ATP, gradually diminish as these forms are catabolized.
During reperfusion, we see the opposite. We see the low-energy phosphates gradually decrease as high-energy phosphates are resynthesized. It looks as if the ratio of creatine phosphate to ATP in the inosine-supplied heart is much higher than in the non-inosine-supplied heart.
Although clearly the big story is going to be the creatine phosphate. That's exciting. That's good. I like that. I always like good experiments.
These experiments seem to suggest that inosine might be a valuable therapy.
Right, exactly. In fact, they're doing this clinically in Russia. They're buying inosine from the Japanese and feeding it to high-risk patients. It should be useful to anybody with a history of multiple infarctions or with stroke.
And what do the data show?
The data are too messy.
That's a problem with uncontrolled clinical studies, isn't it?
Mm-hmm. I didn't know they were doing this till this week.
I suppose the immediate objection to this kind of therapy would be that one is attempting to deliver a pharmaceutical to a tissue whose very problem derives from a deficit in perfusion.
Right. Well, it's certainly true that flow is the dominant factor governing delivery and washout of metabolites to the myocardium, whether it's in normal or hypoperfused regions of the heart. But it is still true that diffusion can play a role, and during severe injury, diffusion must become the dominant process.
Because the Langendorf rat hearts will survive for only a few hours, the group also uses a fetal mouse heart organ culture, which can proceed all the way to the real endpoint of ischemia, frank necrosis.
One of the things we can use the cultured heart preparation for is to assess the effects of an intervention directly on myocardial tissue independently of flow, and then begin to sort out in any given setting whether the end result, cell death, can be attributed to a constellation of metabolic processes or whether they are flow dependent, exogenously determined. The isolated heart and culture does not depend on any exogenous neural or humoral factors unless we put them in the culture medium. It depends only on what you give it. And the surprising result is that supplying inosine during the period of injury, and it had to be during the period of injury, not just during recovery, salvaged at least 25% of the cells. That's what we learned.